Welcome back to the Deep Dive. For all you orthopedic residents tuning in, especially if you're gearing up for those big exams, FRCS, fellowships, the drill, some topics just feel, well, heavier than others.
Definitely.
And calcaneal fractures, they're right up there. On the surface, maybe just another fracture, but they are notoriously complex, aren't they?
Yeah.
High stakes for the patient long term, and definitely something that can cause a bit of anxiety.
That's a good way to put it. They demand respect.
Okay, so let's unpack this today. We're doing a proper deep dive into calcaneal fractures.
Yeah.
Everything you really need to get your head around, turning the complexity into clear, usable insights. For your exams, yes, but maybe more importantly for when you're actually managing these patients.
Exactly.
And just so you know, this deep dive is based on the fantastic Ortho Made Simple notes you can find over at mokyingren.sg. These were put together by Dr. Mok Ying Ren. He's a sports surgeon at National University Hospital in Singapore, got his FRCS back in 2022. Really great stuff, and we're excited to walk you through the key points.
Yeah, it's a solid resource. And look, this isn't just about memorizing facts for an exam. It's about really grasping the subtleties from the moment that patient hits the door, to the long-term picture.
Right.
These are common injuries, and the decisions, they're genuinely nuanced. Getting a solid handle on this now, it's going to be invaluable out there.
Absolutely. So let's imagine the patient walks in, maybe fell off a ladder, landed hard on their heels. What are the immediate things flashing in your mind? The red flags. And maybe even more importantly, what else should you be worried about, given how these usually happen?
Great question. That mechanism, usually a fall from height, is your first big clue. It tells you this isn't just a foot problem. Think of the calcaneus fracture as a potential sentinel injury.
Sentinel injury, yes.
Yeah, it signals that you need to look wider. Yeah. Systemically, what else could be injured? Well, obviously the other calcaneum bilateral injuries aren't uncommon. Then work your way up. Ankle, tibia, knee, femur, hip, maybe even the acetabulum or pelvis.
The whole chain.
The whole kinetic chain, exactly. And crucially, you must screen the lumbar spine. Compression fractures there are commonly associated. Missing that. Big problem. So it's a top-to-toe check, really.
That makes total sense. Axial load injuries.
Oh,
okay,
no.
So zooming back into the calcaneus itself, I've heard the term constant fragment thrown around. What exactly is that, and why is it, constant?
The constant fragment. Yes, that's a really key piece of anatomy to understand for these fractures. It's the anteromedial part, basically. The sustentaculum tali and the middle facet sit on it.
Sustentaculum tali, middle facet, got it.
And interestingly, the FHL tendon, flexor hallucis longus, runs right underneath it. Now, the reason it tends to stay put, why it's relatively undisplaced in most fractures, hence constant, is down to some really strong ligaments holding it tight.
Ligaments?
Yeah, three main ones attach right to the sustentaculum. The tibiocalcaneal ligament, which is part of the deltoid complex, the talocalcaneal ligament, and the calcaneonavicular ligament, the spring ligament.
Wow, okay.
Those guys are strong. They provide a lot of stability to that specific fragment, even when the rest of the calcaneus is significantly disrupted. It becomes an important anchor point if you're doing surgery.
Understood. So those ligaments really lock it down.
Yeah.
Makes sense. Okay, sticking with anatomy for a second. How many actual joint surfaces articulating facets does the calcaneus have? And what do they connect with?
Good question, because understanding the joint involvement is critical for thinking about arthritis later. There are four main articulating facets. Three of them articulate with the talus above.
With the talus, okay.
Yep. You've got the anterior facet, the middle facet, which remember is on that constant fragment, the sustentaculum talus, and then the large posterior facet.
Anterior, middle, posterior, all with the talus. And the fourth?
The fourth one articulates anteriorly with the cuboid bone, so talus above, cuboid in front. Knowing these helps you appreciate why intra-articular fractures, especially involving that big posterior facet, can be so problematic.
Right, multiple joints involved potentially. Okay, so we've done the initial check, thought about the whole patient, got the basic anatomy down. Now, imaging. Let's start with plain x-rays. What are the key angles or views you're really focusing on?
Okay, x-rays. Two angles are absolutely fundamental here. First is Bowler's angle. Normally, it should be somewhere between 25 and 40 degrees.
Bowler's 25 to 40 degrees. How do you measure it?
You draw two lines. Line one goes from the highest point of the posterior facet to the highest point of the calcaneal tuberosity, the back of the heel bone. Line two goes from the highest point of the anterior process and the highest point of the posterior facet.
Okay.
The key thing, in a calcaneal fracture with collapse, this angle gets smaller. It's reduced. That tells you the posterior facet has dropped.
Reduced Bowler's angle. Got it. What's the second angle?
The second one is the angle of Gissane. This one's normally bigger, around 120 to 140 degrees.
Just saying, 120 to 140.
Yeah. Again, two lines. One runs along the slope of the posterior facet. The other runs from the anterior process down along the slope towards the bottom of the posterior facet. Think of it as measuring the dip where the facets meet.
Okay, and what happens to Gissane's angle in a fracture?
This one typically gets wider. It increases. It basically signals that the subtalar joint structure is disrupted.
So bolus reduces, Gissane widens.
Gotcha. Any other key X-ray views?
Definitely. You'll want a Harris axial view that helps you see heel widening, any varus deformity heel tilting inwards, and if the lateral wall has blown out, that's important for shoe wear later. And then there's Broden's view that's really good for looking directly at the subtalar joint congruity, often used intraoperatively to check your reduction.
Okay, axial for width and varus, Broden's for the joint itself. But X-rays only tell part of the story, right? Moving on to the CT scan. This is where you really see the detail, I imagine. What are you assessing plane by plane?
Oh, absolutely. CT is non-negotiable for surgical planning. Each plane gives you different, vital info. Let's break it down.
Sagittal view, that's your side view. Primarily, you're looking at the extent of the collapse, the depression of that posterior facet, and overall hindfoot alignment. How much height has been lost?
Makes sense. Collapse and sagittal. What about coronal?
Coronal view, this is looking from the front or back. It's crucial for seeing how much the heel has widened, has it splayed out. Also confirms any varus deformity and shows you the extent of any lateral wall blowout if that outer wall is fractured and pushed outwards.
Heel widening, varus, lateral wall, important for function and shoe fit, and axial.
Axial view, looking top down. This is the view used for the Sanders classification, which we'll get to. It also helps you really assess the size and position of that constant fragment, that anteromedial piece.
Right, so each view pieces together the 3D puzzle. Okay, before we jump into fixing it, we need that common language. How do we classify these fractures? You mentioned Sanders.
Yeah, classification is key for communication and guiding treatment. There are two main systems you'll hear about. First is the older Essex-Lopresti classification. It's simpler, divides them broadly into two types based on the secondary fracture line.
Okay, what are the types?
You have the joint depressed type, that's the more common one, maybe 75% of cases. Here, the fracture line goes down through the posterior facet and exits anterior to the Achilles tendon insertion, so the joint surface gets pushed down.
Pushed down, okay. And the other type?
The other is the tongue type. In this one, the secondary fracture line extends further back posteriorly, involving the tuberosity, creating a large tongue of bone that includes part of the articular surface and the Achilles insertion.
Tongue type involves the tuberosity. Got it. And the Sanders.
Right. The Sanders classification is the one we use most often now, especially for surgical planning. It's based specifically on the CT scan, that 30-degree semi-coronal view, right at the widest part of the posterior facet.
Okay, CT-based. How does it work?
It classifies the fracture based on the number of fracture lines entering the posterior facet. So, type 1 is undisplaced, less than 2 millimeter displacement. Type 2 means there's one fracture line splitting the posterior facet into two main pieces. Type 3 has two fracture lines, giving you three main articular fragments. And type 4 is comminuted. The posterior facet is basically shattered into four or more pieces.
1, 2, 3, 4. Based on fracture lines in the joint. Makes sense. Higher number, more complex.
Exactly. It gives you a good idea of the severity of the joint disruption.
So, okay, we've assessed the patient, got the images, classified the fracture. Let's talk acute management. Back in the ER. What's the immediate plan? And are there any common pitfalls here?
Good practical point. Acutely, you're thinking about swelling in soft tissues. So the standard is a Jones bandage. That's the bulky compressive cotton wrap. Elevation is absolutely key. Get that foot up high.
Jones bandage, elevation. Simple enough? Any don'ts?
Yes, a big one, especially for exams. Do not apply a rigid back slab or cast initially.
Oh, interesting. Why not?
Because the swelling in these injuries can be massive. Putting a rigid cast on can drastically increase the pressure within that already compromised soft tissue envelope. It risks compartment syndrome, skin necrosis, really bad complications. So soft compression only initially.
Right, avoid increasing pressure. Crucial point.
Yeah.
Okay, now the big debate. Definitive management. Surgery or no surgery?
Right.
Especially for these more complex displaced fractures. What's the thinking? What does the evidence tell us?
Yeah, this is where it gets really interesting. And honestly, there isn't a single easy answer for every patient, particularly for those really smashed Sanders type 4s.
No clear consensus.
Not entirely. We have several big studies. Buckley's trial from 2002, Agren et al. the UK HFT trial, and some actually showed no significant difference in overall outcomes between operating and not operating, especially in certain groups or fracture types, but it's nuanced.
Okay, break down the nuances. What factors push you towards surgery?
Well, from the injury side of things, fractures that are heavily comminuted or have significant disruption and displacement of the subtalar joint, those carry a really high risk of painful secondary osteoarthritis down the line.
Makes sense. Fix the joint to prevent arthritis.
That's the goal. And even if arthritis does develop later and you need to do a fusion, there's evidence like the Radney study from 2009 suggesting that if you got a better initial reduction with ORIF, the outcomes of that later fusion are better with fewer wound problems.
Okay, so injury factors like comminution and joint disruption favor fixing it. What about patient factors?
Right. Patient factors are huge. The old thinking was maybe just young, active male worker needs surgery. But the Buckley trial, for instance, really challenged that. It found that while overall outcomes weren't different, specific subgroups actually did benefit significantly from surgery.
Oh, okay. Which subgroups were those?
It turned out to be women, patients younger than 30 who had lighter workloads, and also those who weren't involved in workers' compensation claims.
That's really specific, so it's not just about age or activity level.
Exactly. It highlights the need for patient stratification. On the flip side, patients with significant peripheral vascular disease or poorly controlled diabetes. Those are factors that might make you lean away from surgery due to the high risk of wound healing problems and infection.
PVD, diabetes.
No.
Major red flags for surgery.
Definitely. So the bottom line is you have to weigh the fracture pattern against the patient's individual health, their functional demands, their expectations, and have a really detailed discussion with them. It has to be an informed decision they make with you.
That shared decision-making is key. Okay, just want to pause here for a second and remind everyone listening, this deep dive is powered by the excellent Ortho Made Simple Notes from mokyingren.sg, a really great resource to check out for your studies.
Agreed.
All right, so let's say you and the patient decide surgery is the way to go. What are the main goals? What are you actually trying to achieve when you fix one of these fractures?
There are 4 primary surgical aims. First, restore Bowler's angle and calcaneal height. Getting that hind foot alignment back is crucial for function.
Okay, height and bowlers.
Second, restore the width. That widened heel needs to be squeezed back together for proper shoe fitting and to prevent problems down the line, like impingement.
Restore width. Got it.
Third, correct any varus malalignment. You need the heel to be straight, not tilted inwards.
The correct varus?
And fourth, arguably the most critical for long-term pain and function, restore subtalar joint congruity. Get that main joint surface as smooth and anatomical as possible to minimize the risk of arthritis.
Height, width, alignment, and joint surface. Makes sense. So how do you get in there to do that? What are the common surgical approaches, and what do you need to watch out for?
Good question. The approach is critical. The classic approach is the lateral extensile approach. It's an L-shaped incision on the outside of the heel.
The big L incision.
Yeah. It gives you great visualization of the fracture, especially the lateral wall and the posterior facet. The key technical point here is raising a full-thickness flap skin and subcutaneous tissue right down to the periosteum to protect the blood supply to the skin, specifically the lateral calcaneal artery.
Full-thickness flap. Important for wound healing.
Absolutely. Then you dissect periostally, peel the tissues off the bone. You need meticulous handling, often using K-wires to hold the flap retracted gently, because wound breakdown is the major risk with this approach.
Look, that's the extensile lateral. What's the alternative?
The main alternative gaining popularity is the sinus tarsi approach. This uses a much smaller, more horizontal incision over the sinus tarsi area, that little depression on the outside of the ankle.
Smaller incision, less exposure.
Less exposure overall, yes, but it gives good direct access to the subtalar joint. You retract the EDB muscle upwards and the peroneal tendons downwards. It's considered more minimally invasive.
So which one's better, extensile versus sinus tarsi?
Well, that's the debate. The big advantage of the sinus tarsi approach seems to be significantly lower wound complication rates. A meta-analysis by Bai and colleagues in 2018 found rates around 2% for sinus tarsi versus up to 20% for the extensile approach.
Wow, 2% versus 20%. That's a huge difference.
It is. And importantly, that same analysis found no significant difference in functional outcomes or the quality of reduction between the two approaches. So many surgeons are leaning towards sinus tarsi now, especially given the wound risk with the extensile approach.
Makes sense. Less wound risk, similar outcomes. Seems like a good trade-off. Anything critical to avoid with either approach?
Yes. Absolutely critical. Beware the sural nerve. It runs right through the surgical field in both approaches, slightly differently positioned, but it's always at risk. Damage leads to numbness or painful neuroma on the outside of the foot. You have to identify and protect it carefully.
Sural nerve, got it.
Well,
Protect the nerve. Okay, once you're in, regardless of approach, any technical tips or tricks for actually putting the pieces back together?
yeah, there are a few pearls. Often you'll place a shunt pin, like a threaded pin, into the posterior tuberosity fragment. This acts like a joystick to help you pull the heel out of varus and restore length and alignment.
Shun's pin is a joystick. Clever.
You might use a laminar spreader carefully within the fracture site to gently push the collapsed fragments back up, especially the posterior facet. Then you'll typically use K-wires temporarily to hold the reduction. For definitive fixation under the joint surface, raft screws are often used, small screws placed just beneath the articular cartilage, often secured to that constant fragment medially to support the joint surface.
Raft screws under the joint. Okay. What about the empty space left after you reduce it?
Good point. That central void often needs filling. You can use bone graft, either allograft, donor bone, or autograft, maybe from the iliac crest or bone substitutes. This provides structural support while the fracture heals. Then finally, you apply your plate and screws for definitive stability. And of course, MIS techniques, using smaller incisions and percutaneous screws, are also evolving.
Okay, so plate and screws. Doesn't matter which you use. Screws alone versus a plate. And is that bone graft always needed?
Good questions. On screws versus plates, a study by Pitts et al. A few years back found no significant difference in outcomes, how well the angles were restored, or complication rates. So it often comes down to surgeon preference and the specific fracture pattern. Maybe screws alone for simpler patterns, plates for more complex ones needing more robust fixation.
Okay, so choice depends. What about the graft? Always necessary?
Not necessarily always. Studies looking at autograft and allograft have shown that while grafting might sometimes lead to slightly better restoration of the radiographic angles, like Bowler's angle, it doesn't seem to consistently improve clinical outcomes or reduce complications compared to not grafting. So, again, it's often a surgeon and patient decision based on the size of the defect and the perceived stability of the reduction. Bone substitutes are also an option there.
Interesting. So graft isn't mandatory, but might help with the angles. Okay, let's circle back to some of those big trials you mentioned. The UKHEFT trial, you said it showed no difference between surgery and non-op, but had limitations.
Exactly. UKAEFT. Randomized trial, 151 patients. Headline. No difference. But you have to look at the fine print. They excluded the worst fractures. Sanders 3s and 4s were out.
Ah, so only the less severe ones were included.
Pretty much. That's a huge selection bias right there. If you only study the fractures that might do okay anyway, you're less likely to see a benefit from surgery. Plus, only about 30% of eligible patients even agreed to be randomized, and everyone who got surgery had the extensile lateral approach, with its higher wound risk potentially dragging down the operative group's results.
So the no difference finding needs a big asterisk next to it.
A very big asterisk. It doesn't necessarily apply to the more severe fractures we often grapple with.
Okay. And the Buckley trial.
Yeah.
You mentioned the subgroup findings, but what was the overall result?
The Buckley trial was larger, over 500 patients, and did include more severe fractures. Overall, like HEFT, it found no statistically significant difference in the main outcome scores between operative, again, extensile lateral approach, and non-operative treatment for displaced intra-articular fractures as a whole.
No difference overall there either.
Not in the primary analysis. But as we discussed, the crucial finding was, in those subgroups, women, younger patients with light work, no workers' comp lists, they clearly did better with surgery. This really tells us that the average result might hide important differences for specific patient types.
That subgroup analysis seems key then. It really pushes towards more personalized decision-making.
Precisely.
Okay, this brings up another tricky question. Given the difficulty in treating some of these, especially Sanders 4s, and the risk of arthritis, what about doing a primary fusion, just fusing the subtalar joint right away?
Yeah, primary arthrodesis, it's definitely a controversial, but it's a valid consideration, particularly for those very severe Sanders type 4 fractures where the joint surface is just completely destroyed.
What's the argument for it?
Well, the original Buckley trial noted that about 25% of their Sanders 4 patients ended up needing a secondary fusion within 2 years anyway because of pain and arthritis. So the argument is, if a fusion is likely needed eventually, Why put the patient through 2 major surgeries? Maybe just do the ORIF infusion all at once.
Save them a second operation.
Potentially. And another Buckley paper from 2014 actually randomized Sanders 4 patients to either ORIF alone or ORIF plus primary fusion. They found no real difference in functional outcomes between the groups. So primary fusion didn't seem to make things worse functionally, and it might save costs and recovery time.
So it's a reasonable option in select cases.
It seems to be. The authors basically concluded it remains a choice for the surgeon and the well-informed patient, especially in those highly comminuted type 4 patterns where salvaging a functional joint seems unlikely.
Okay, and let's say you don't do a primary fusion, you do an ORIF. Does getting that initial good reduction help if they do need a fusion later on?
Yes, that's where the Radney study comes in again. Comparing patients who had non-op treatment then fusion versus ORIF then fusion. The group that had the initial ORIF had better functional scores and fewer wound problems with their subsequent fusion.
So a good initial ORIF potentially sets them up better, even if fusion is needed later.
That seems to be the case. Restoring height, alignment, and reducing deformity early on likely makes the later fusion technically easier and more successful.
Right. Okay. Connecting all this.
Yeah.
Even with the best treatment, things can still go wrong. What are the main complications residents really need to be aware of and counsel patients about?
Absolutely. Complications are a reality. Number 1 is probably wound complications, especially with the extensile approach infection, skin necrosis, dehiscence. It's a major concern.
Wound problems. What else?
Subtalar arthritis. Even with a perfect reduction, damage to the cartilage at the time of injury can lead to painful arthritis down the line. It's very common. Then there's subfibular impingement.
Subfibular impingement.
Yeah, if the heel remains widened or drifts into valgus after healing, the outside of the calcaneus can rub against the bottom of the fibula, causing pain and often irritating the peroneal tendons that run nearby.
Ouch. Okay. And the last big one.
Malunion. The fracture heals, but in a bad position. Maybe the height isn't restored, or there's significant varus or valgus, or the joint is incongruent. This leads to chronic pain, stiffness, difficulty with shoes, and altered gait mechanics.
Wound issues, arthritis, impingement, malunion. Quite a list.
Yeah.
For that last one, malunion, especially if they've lost height, what's the typical salvage surgery?
The go-to salvage procedure for a symptomatic calcaneal malunion with loss of height and significant deformity is usually a distraction bone block subtalar arthrodesis.
Okay, break that down. Distraction, bone block, arthrodesis.
Right. Arthrodesis means fusing the subtalar joint to eliminate painful motion. The distraction bone block part is key. You surgically rebreak or cut the malunited calcaneus, distract it, pull it apart to restore height and correct the alignment, and then insert a structural bone graft, the block, into the gap before fusing the joint in the corrected position.
So you're essentially rebuilding the shape and then fusing it.
Exactly. It addresses both the deformity and the arthritic pain. It's a complex salvage procedure, but can be very effective for debilitating malunions.
Oh. Okay, what an incredibly thorough journey through calcaneal fractures. We've gone from that initial assessment, thinking about associated injuries, understanding that constant fragment, nailing down the X-ray angles and CT findings, through the classifications, the whole operative versus non-operative debate, surgical aims, the different approaches like extensile and sinus tarsi, technical pearls, the role of graft, those key trials like HFT and Buckley, thinking about primary fusion, and finally, complications and salvage. That really gives you a solid framework.
Yeah, hopefully it pulls together a lot of the key concepts. The main thing is to take this knowledge, synthesize it, and apply that critical thinking to each individual patient you see. Because no 2 fractures and no 2 patients are exactly alike.
Absolutely. Your ability to weigh all these factors, the fracture pattern, the patient's health, their life, the evidence, that's what makes the difference.
That's the art and science of it.
So thinking about all this, what really stands out to you, listening in, how might this influence how you approach these challenging injuries in your practice? We really hope this deep dive has given you some solid ground to stand on. And remember, this deep dive drew heavily from the Ortho Made Simple notes, which you can find at mokyingren.sg, truly a valuable resource.
Definitely check it out.
As you continue on your path, learning, training, healing patients, hold on to this piece of wisdom. The desire of the righteous ends only in good, the expectation of the wicked in wrath. That's from Proverbs 11.23. May your desire for good, for knowledge, and for healing always be your guide. Thanks for joining us on the Deep Dive.